If you look at the consensus or guidelines from different societies, these are what has been recommended for ventilating a patient who is on VV ECMO. The main objective for all, whatever from all the guidelines, whether it's the ELSO guidelines or European network or the consensus conference, your main objective there when you ventilate a patient who is on VV ECMO is you want to provide the lung rest. That is the main objective. It can be any mode, but pressure control is a preferred one. You try to keep your tidal volume as less as possible. That is ultra protective ventilation, trying to target less than 4 ml per kg. You don't cross your peak pressure more than 25 in this patient. That is extremely important. You try to cut down on your respiratory rate to as low as possible, that is less than 10 breaths, and keep your FiO2 as low, less than 0.4 in this patient. That should be enough. And then you titrate your PEEP based upon individual patient. So these are the recommendations or consensus that are being suggested for the management of ventilation in a patient who is on VV ECMO. So how do these help us in minimizing the ventilation-induced lung injury? Like we have seen before, these are all the different objectives what we have to limit the alveolar strain that we will achieve because you're going for an ultra-protective lung ventilation, and mainly by decreasing the respiratory rate. That's extremely important. You have to decrease the respiratory rate, and that's the one that translates into decreasing the alveolar strain there. And you limit your atelectasis trauma by maintaining a reasonable level of PEEP. You don't keep it very high like you keep it before your patient goes on ECMO, but you try to maintain a reasonable level of PEEP, that individualizing from patient to patient there. You prevent a reabsorption atelectasis by decreasing the ventilator FiO2 and avoid over distension, for which you can monitor the transpulmonary pressures or probably use NAVA if required in these cases there. So what do we do once we go on ECMO, on VV ECMO in a patient? This is what you do. Once you go on VV ECMO, you have stabilized your flows, you have seen the saturation is improving, and you have make sure all ECMO related things are satisfactory. You decrease your FiO2. You try to come down to less than 50% or less than 40% from the ventilator side. You decrease the respiratory rate to bare minimal, that is 10 or less than 10 breaths. You try to come down on PEEP in a gradual way and try to titrate it to what the patient really needs. Put them on a pressure control ventilation and make sure that the P peak pressure doesn't go more than 25, and you're ventilating with a very low tidal volumes or a rest lung or an ultra protective tidal volumes of less than 4 ml per kg. So this is how you do, and this is what you do at least first 48 to 72 hours to give lung ample time to rest and probably start the process of recovery. Further, how do you go down? Further, you go down based upon how the patient is and individualizing it patient to patient. So again, you have different timelines on how and on what for the lung to recover. In some patients, it may be a reasonably quick recovery happening in a week or two. In some, it may take few months also. So you keep a close watch on the lung, how it is based upon your ventilator, what do you get from your ventilator graphics and or from the ventilation parameters based assessment. Along with that, your clinical examination, your radiological assessment, all these things will guide you in slowly, gradually increasing your ventilator settings. You slowly go up on your respiratory rate, if required go up on your FiO2, try to optimize your PEEP, but in any case, you will not cross that P plateau of more than 25. You will not cause any additional damage to the lung because of your ventilator settings, and as the lung starts recovering, you then slowly come down an ECMO. That is how you go for it. In this process, to facilitate this, you do a lot of things. We see some of them down the line, but one thing which you commonly do for all these patients is to tracheostomize them. You do tracheostomize them, you try to rehabilitate them, get them out of the bed, and then you try to promote the spontaneous ventilation. So they don't come under typical ventilation settings, but these things do make a significant difference and help. An early tracheostomy, mobilization of the patient, and promoting spontaneous ventilation there will make a huge difference.